Syphilis during pregnancy is a completely treatable infection, but it is still killing babies before birth. Now, why is this happening? This is happening because either the syphilitic infection is not being picked up during pregnancy or it is being treated too late. So, let's talk about syphilis today and how a timely injection can save a baby's life. Now, what is syphilis? Syphilis is a sexually transmitted infection caused by a bacterium, Treponema pallidum. Now, syphilis infection during pregnancy is especially dangerous because this bacterium can cross the placenta and then infect the growing baby inside the mother's womb. So, syphilitic infection has got many stages. So, first is primary syphilis, in which the patient would have a painless ulcer somewhere maybe in the oral mucosa or in the anus or vagina. And because it is painless, the patient really would not know about it. And this ulcer would heal on its own in the next 2 to 8 weeks. Then comes the stage of secondary syphilis, in which the patient would have a maculopapular rash, especially on the palms and soles. This rash is reddish to brownish in color. It is non-itchy, can be accompanied by some fever as well as lymphadenopathy. Now, this picture is actually confused with any other viral infection. Then is the stage of latent syphilis, in which the patient would be asymptomatic but the serological test would be positive. Now, latent stage is divided into early and late depending upon the time interval since the exposure. So, if you take the history of the patient and you find out that the exposure to syphilitic infection was less than a year, then this is known as early latent. And if the exposure happened more than a year back, then that is late latent syphilis. Now, the final stage would be tertiary syphilis, in which any of the organ system would be involved. So, you can have neurosyphilis when the CNS is involved and the patient would have dementia or impaired gait. Then it can involve the cardiovascular system, in which aortic aneurysm is seen. It can involve basically any organ. There are ulcerative gummas which are seen on the skin and the bone. Now, there is something called vertical transmission, meaning that the bacterium passes through the placenta and infects the baby. So, this vertical transmission, that is transmission of infection from the mother to the growing baby, it happens maximum in primary syphilis, almost 100%. In secondary syphilis, the vertical transmission risk is somewhere around 70%. It decreases to about 40% in latent syphilis and about 10% in tertiary syphilis. So that is why it is so very, very important that we catch hold or we diagnose syphilis early and treat it early. Now, why is syphilis so dangerous during pregnancy? Because it is associated with many complications such as miscarriages, preterm labor, low birth weight baby, stillbirths, and the most scary of all complications is congenital syphilis in the baby. Now, because the infection can go on from the placenta and infect the baby, so congenital syphilis in these babies has been divided into early and late congenital syphilis depending upon the time that the infection manifests in the baby after birth. So, if you find features of syphilis in the baby within 2 years of its birth, then this is known as early congenital syphilis. And if the features or the infection appears after 2 years, then this is known as late congenital syphilis. Now, in early congenital syphilis, generally we'll find that the newborn within 1 week of delivery has a lot of rhinitis, that is a lot of mucoid discharge through the nose. And if this discharge is seen under the dark field microscopy, we actually can see the spirochetes. Then this baby also tends to have rash during the 2nd week of its birth. This rash is reddish maculopapular and mainly seen on the back and the buttocks and even soles of the feet. The baby can have hepatomegaly or enlarged liver and jaundice, and baby also in early congenital syphilis can have multiple lymph nodes enlarged throughout the body. In late congenital syphilis, almost any organ of the baby can be affected. It can lead to blindness, deafness, joint problems, especially Clutton's joint. Then even in oral cavity, specific Hutchinson's teeth or mulberry molars are seen in congenital syphilis. So this is a disease which has a lot of effect on the life of the baby. And that is why it is so very, very important that we test all pregnant women for syphilis and treat the pregnant women as soon as possible so that her unborn baby does not get the syphilitic infection. So the million-dollar question is, how do you screen pregnant women for syphilis? So you need to do the screening test for syphilis, that is either VDRL or RPR. They are also known as non-treponemal tests. So you do VDRL quantitative, that is you do the titers of VDRL also, and if the titer is more than 1 in 8, then you need to confirm the infection by using a confirmatory test. So there are two common confirmatory tests which are done. One is TPHA, that is Treponema pallidum heme agglutination, and the other is FTA absorbed. So you can do either of these tests, and if they are positive, then it is confirmed that the pregnant woman has got syphilitic infection. So again I am repeating, you do VDRL positive, you please do VDRL titers. If more than 1 in 8, confirm using TPHA. So now your screening test and your confirmatory test both are positive. So this labels the woman as being syphilis positive. Now, when do you do VDRL test in pregnant women? So, at the first contact itself, the first time when the pregnant woman is coming to you in antenatal, you need to screen her using either RPR or VDRL test. Now, you know that this woman has got the infection. What do you do next? Next, of course, is treatment of syphilis. So, for treatment of syphilis, there is only one drug, and that is injection benzathine penicillin G. You give this injection 2.4 million units intramuscularly. Now, how many doses are to be given? This depends upon the stage of syphilitic infection. So, in primary, secondary or early latent syphilis, maximum of 2 doses weekly are given. But what happens is that mostly the pregnant women do not really know when they were exposed to the syphilitic infection. That means either the infection is late latent or it is of unknown duration. So the best treatment for pregnant women with syphilis is 3 injections or 3 doses of injection benzathine penicillin G, 2.4 million units weekly for 3 weeks. Now in case a woman misses her dose, she does not come back to you for more than 9 days, then you need to repeat the 3 doses again. So this is very, very important, and there is no other alternative to penicillin because this is the only drug which would cross the placenta and protect the baby also. Now what if your patient is allergic to penicillin? Then the next best option is to do penicillin desensitization. Now, in case, it's not possible for you to do penicillin desensitization, some guidelines have recommended oral antibiotic erythromycin 500 milligram 4 times a day for 14 days or injection ceftriaxone 1 gram intramuscularly for 14 days. But we need to remember that these 2 antibiotics do not cross the placenta, so they do not offer any protection to the growing fetus. So once this baby is delivered, then we have to treat the baby. So penicillin is the only antibiotic which will cross the placenta and protect the baby also from congenital syphilis. Now, how do you follow these pregnant women whom you have treated for syphilis? You repeat their VDRL titers. So, if you treated the woman at less than 24 weeks period of gestation, then you need to repeat the titers at 32 weeks POG and at delivery. And if you treated the woman after 24 weeks of period of gestation, then you need to repeat the VDRL titers at delivery. Now, why is this so? Because we do not repeat the VDRL titers within 8 weeks of treatment, because once we give injection benzathine penicillin, for the first couple of weeks the VDRL titer may actually increase. So it is advisable and recommended not to repeat titers till at least 8 weeks of treatment. And if on repeat titers, you find that there is a four-fold increase. That is from 1:8. Now, suppose the titers have become 1:32. So that would indicate either the treatment has failed or it is a case of reinfection. Now, next important thing is, how would you evaluate the growing baby for congenital syphilis? So you need to do an ultrasound and see for any features suggestive of congenital syphilis in the baby. So you look for hepatosplenomegaly, you look for any other features of hydrops, ascites, you look for whether the placenta is more thick than the period of gestation, and you can even do a Doppler, in which you would find that babies who have congenital syphilis have an increased peak systolic volume in the middle cerebral artery. So what do you do when these women deliver? You always send the placenta for histopathology and you inform the pediatric team. So the pediatric team would then they would send VDRL for the baby. They would do a CBC, HIV testing. They'll do a skeletal survey, that is, they'll take the x-rays of the long bones and do an ultrasound abdomen of the baby to look for hepatosplenomegaly or ascites. If they find that the baby has got any features of congenital syphilis, or if there is any suspicion of syphilis in the baby, then they would be treating the baby with benzyl penicillin for the next 10 to 14 days. And another important thing is, please do not forget to test and treat the partner of this pregnant woman, because unless the partner is treated, it will always lead to reinfection. So whenever you have a patient of VDRL positive, don't panic. We will just go through it again. You have VDRL positive, you get the titers. If the titer is more than 1:8, do a confirmatory test, maybe TPHA. Now, if your screening and confirmatory test both are positive, this means that the woman has got syphilis infection. So next is, treat the patient as early as possible with injection benzathine penicillin 2.4 million units intramuscularly weekly for 3 weeks. Then you monitor this patient with repeat VDRL titers. If you have treated her before 24 weeks of gestation, repeat VDRL titer at 32 weeks and at delivery. And if you have treated her after 24 weeks, you repeat VDRL at delivery. If there is a four-fold rise of titers, that means either your infection, your treatment is not adequate, or there has been reinfection. Evaluate the baby for congenital syphilis by doing an ultrasound. And at delivery, send the placenta for histopathology and inform the pediatrician so that they can also evaluate the newborn now and can treat the newborn effectively and early. Always test and treat the partner. So by following these simple steps, we will be able to save many babies from congenital syphilis. So be aware and be safe, and always remember that timely injection of benzathine penicillin can save so many babies from morbidity and mortality.